Hello everyone and welcome to the start of our academic program for the year 2021. My name is Kaylin Apollos and I'm going to be discussing the management of acute salpingo-ulceritis or the management of acute pelvic inflammatory disease, looking at what our evidence has directed us towards. If we look at the definition, there is quite a lack of precise disease definition, with the main focus being that it is an acute ascending polymicrobial infection of the upper genital tract, and it may involve any or all of the uterus, fallopian tubes, and ovaries. This is often accompanied by involvement of the neighboring pelvic organs, such as structures related to endometritis, salpingitis, ulceritis, peritonitis, perihepatitis. Perihepatitis, also known as Fitzhugh-Curtis syndrome, is mostly due to the inflammation of the liver capsule. The disease is usually sexually transmitted up to 85%, of which can be acute or chronic. For the purpose of this talk, we are going to be focusing on the acute management. 15% of cases of PID can be due to the colonization of the lower genital tract from enteric bugs or respiratory pathogens. One should always keep in mind the genitourinary tuberculosis, which can also be a contributing or a causative factor. However, genitourinary TB is also an entire discussion on its own, for which we will not be focusing on. When looking at the microbiology of PID, it is commonly caused by the cervical organisms being Neisseria gonorrhea and Chlamydia trachomatis, which is why our treatment therapy is always aimed at coverage for these two particular bugs, even if a cervical swab is negative. The vaginal microflora can also be causative or contributing bugs towards the diagnosis of pelvic inflammatory disease, in particular the streptococci, the anaerobes, and Gardnerella vaginalis, which is the main culprit in bacterial vaginosis. Bacterial vaginosis can be concurrent or contributing factor for PID. When deciding to cover for anaerobes, the treatment is quite controversial. Although several studies of women with PID have demonstrated the presence of anaerobes at initial presentation, there are no studies that demonstrate that inclusion of anaerobic coverage is superior to antibiotic regimens without it. Therefore, the latest Cochrane database system has reviewed and advised us to add anaerobic cover, in particularly severe disease, immunocompromised patients, recent instrumentation, or if we suspect bacterial vaginosis concurrent. 2. This is majority of our patient population. Therefore, our guidelines are mostly aimed at adding in anaerobic cover. When we look at the risk factors for PID, there are quite a host that have been identified. However, PID is also mostly a clinical diagnosis, but some of these risk factors can help to guide your direction of therapy. If a patient presents with an early sexual debut, younger than the age of 25, if they have a new sexual partner, multiple sexual partners, or a symptomatic sexual partner, if they are below parity, history of previous PID or STDs, if they have other concomitant STDs, if they are below socioeconomic factors or status, which is majority of our patient population, if they have concurrent bacterial vaginosis, as well as sexual intercourse during menses. This is mostly due to the loss of the defensive mechanisms that are associated in protecting us from pelvic inflammatory disease. The presentation of pelvic inflammatory disease can be wide and vary. However, it is to note that it's mostly a clinical diagnosis. These patients present with lower abdominal pain, that normally worsens with coitus is usually bilateral and of acute onset. There may or may not be a vaginal discharge, which may or may not be foul smelling. The foul smell is also unfortunately subjective, but as gynecologists, I think we can identify it. The clinical signs associated with pelvic inflammatory disease depend on the stability and the severity of your patient, but they mostly include abdominal tenderness or peritonitis with or without rebound tenderness, pain in the right upper quadrant, in particularly consideration of Fitzhugh-Curtis syndrome, a mucopurulent discharge associated with cervical excitation tenderness or adnexal tenderness, a triad of lower abdominal pain plus cervical excitation tenderness and adnexal or uterine tenderness is normally high enough for us to suspect pelvic inflammatory disease. Most of the patients will also have one of the following, being pyrexia, mucopurulent discharge, raised inflammatory markers, or the evidence of white cells on saline microscopy of vaginal secretions. When making the diagnosis of pelvic inflammatory disease, we should always consider differential diagnosis and use the tools of investigations to help us rule it out. Common GIT causes include appendicitis, cholecystitis, or inflammatory bowel disease. Renal differentials include pyelonephritis, cystitis, kidney stones, and urethritis. Other obstetrical gynecological causes could be an ectopic pregnancy, severe dysmenorrhea, an intrauterine pregnancy complication, an ovarian cyst, tumor, or even an ovarian torsion. When we classify PID, we use the Gainesville staging or the Gainesville classification. It is still the recommended classification. It has a stage of 1 to 4, depending on the severity and the symptoms of the patient. Essentially, stage 1 is early salpingitis, localized to the adnexa. They will fulfill the CDC major diagnostic criteria and more than one of its minor criteria, but they don't have overt peritonitis. Stage 2 is essentially the above with peritonitis or late salpingitis and peritonitis. Stage 3 almost always have evidence of a pyosalpinx, a tubo-ovarian mass, or tubal occlusion, either physical or ultrasound examination. And stage 4 is generally a ruptured tubo-ovarian abscess or tubo-ovarian complex with generalized peritonitis and septicemia. There has been recommendations to add a stage 5 in our severely shocked patients that present with adult respiratory distress syndrome, but this has not been allocated as yet. When deciding which patients require outpatient therapy versus inpatient therapy, we need to be able to identify the indications for admission. We still base our decisions on the Gainesville classification, usually with patients from grade 3 and above. However, each patient should be individualized based on your clinical judgment and the clinical picture and stability of the patient. Common reasons for admission require severe clinical illness, especially associated with high fever, nausea, vomiting, severe abdominal pain, any patient with complicated PID with pelvic abscesses, including tubo-ovarian abscesses, any severe peritonitis requiring surgical management, especially if you suspect ovarian torsion or a ruptured tubo-ovarian abscess, inability to take oral medications due to nausea and vomiting, pregnant patients with the diagnosis of PID require admission, lack of response or tolerance to oral medication, especially due to severe vomiting, and concern for non-adherence to therapy. This is quite a contributing factor for our patient population, as a lot of our patients come from low socioeconomic status, so the non-adherence becomes quite a substantial factor. When deciding who can qualify for inpatient versus outpatient therapy for PID, a PEACH trial was done in 2002. It was a randomized controlled trial to assess the effectiveness for treatment of inpatient versus outpatient therapy for the stable patient, essentially your Gainesville classification stage 1 to 2. In this trial, 831 women with lower abdominal pain, uterine or adnexal tenderness, and mucopurulent cervicitis or untreated gonococcal chlamydial infection were randomly assigned to either receive IV therapy or oral therapy. The short-term clinical and microbiologic outcomes and long-term reproductive outcomes, especially the complications associated with PID, were noted to be similar between the two groups. There was essentially no difference in treating our patients inpatient or outpatient for grades 1 to 2 or stable patients. Therefore, we opt to treat outpatient for stage 1 to 2 and generally inpatient for stages 3 and above. The following is a recommendation for the outpatient therapy with the use of antibiotics. It is to note that all outpatients require investigations alongside with the diagnosis of PID. These investigations will be discussed later. For now, we are going to focus on the adequate antibiotic of choice in the treatment in an outpatient setting. As a clinician, we should always treat our patient's symptoms, especially with the use of analgesia. The latest Cochrane and English journal have recommended the following antibiotics. A single IMI dose of a long-acting cephalosporin as well as a tetracycline in the form of 2 grams IMI ceftriaxone and doxycycline 100 milligrams twice a day for 14 days. The addition of flagyl is only advised if the patients had gynecological instrumentation or the presence of bacterial vaginosis. In the UK National Guidelines, last updated in 2011, the recommendations were similar. However, the dosage was different in the form of 500 milligrams ceftriaxone IMI, as well as doxycycline and the addition of flagyl, whether or not they had the gynecological instrumentation or the BV present. Alternative drugs to use in the case of being unable to tolerate or have the availability of cephalosporin is ofofloxacin, 400 milligrams twice a day for 14 days, with the addition of flagyl. Ofofloxacin is not a widespread use drug, and availability might become an issue, especially in our setting. However, it is of to note that this is the guided alternative. The IMI ceftriaxone injection is also extremely painful, so please warn the patients before administering it. Some experts, including the European Sexually Transmitted Infections Guidelines Editorial Board, do routinely include anaerobic coverage for mild to moderate PID. The CDC recommends considering anaerobic coverage in the setting, i.e., consider anaerobic coverage in most of your PID patients, which is why in our directed therapy, we make the use of anaerobic cover. If we look at the PID outpatient treatment in South Africa, our recommendations come from the CDC. They are guided from the UK as well as taking our patient population into account using and working alongside the Department of National Health Guidelines. Therefore, we treat them with a stacked dose of a cephalosporin, being ceftriaxone 250 milligrams IMI, or cefotaxime can also be used, followed by a stacked dose of azithromycin 1 gram, thereafter a 14-day outpatient course of doxycycline 100 milligrams twice a day with or without flagyl 400 milligrams twice a day. The decision to add flagyl should be patient-based and patient-orientated. However, we find that a lot of our patient population have multiple risk factors. Therefore, the decision to add flagyl is mostly done. The alternative we use in case the patient is unable to tolerate doxycycline is azithromycin. The course duration changes depending on the drug that you use, doxycycline being a 14-day course, but azithromycin being a 7-day course. Both of these antibiotics offer adequate coverage for the different durations, all based on the half-lives of the drugs. Flagyl, also directed as a 14-day course, especially in the presence of a pelvic abscess, if unable to be tolerated by the patient, the alternative is clindamycin, which can be given 6-hourly for 14 days. To take a tablet 4 times a day for 14 days is quite taxing on patients. Therefore, it is mostly recommended to use flagyl. However, if allergic or unable to tolerate it, clindamycin is the next resort. So what are the main differences between a hospital treatment versus a community health center treatment? Hospitals use protocols based on factors such as cost, population, availability of the drugs, and the evidence-based guidelines. The Department of Health National Guidelines, seen here for the sexually transmitted infections management, last updated in 2019, is aimed at treatment in the community health centers where fewer doctors and more nursing staff are present. These guidelines are directed to treat the symptoms and not to treat the diagnosis of pelvic inflammatory disease. Henceforth, we will see mostly stacked doses compared to the hospital treatment of 14 days duration. If you look at the flow charts available for the community health centers, they are quite easy to follow and self-explanatory. If you look at the treatment for vaginal discharge syndrome, if they make the diagnosis of cervicitis with a vaginal discharge, the treatment is a stat dose of ceftriaxone and a stat dose of azithromycin, as well as analgesia. If they suspect concomitant bacterial vaginosis, or the vagina or the vulva is noted to be swollen, erythematous, and pruritic, then the addition of flagyl can be added for 7 days, or a stat dose of flagyl 2 grams can be given, followed by clotrimazole vaginal pessary or clotrimazole vaginal cream. These guidelines are mostly aimed at nurse or midwife-directed therapy. The last directed guideline for the community health centers is a simple approach to severe low abdominal pain with or without vaginal discharge. The treatment remains the same as a stat dose of ceftriaxone 250 milligrams, a stat dose of azithromycin 1 gram, and flagyl 400 for 7 days. In any severely ill patients, the guidelines graciously state to set up an IV line, treat shock, and refer the patient immediately, alongside giving a stat dose of IV ceftriaxone and flagyl 400 milligrams orally, as well as adequate analgesia. These guidelines from the Department of National Health, like I say, are directed at community health centers. However, our guidelines are directed at Level 1, Level 2, and Level 3 care, which is why we tend to not follow these ones mentioned, but rather give our patients stat doses of ceftriaxone, stat dose of azithromycin, followed by a 14-day course of doxycycline and flagyl, alongside with analgesia. So, How do we manage inpatient PID? When we've made the decision to admit our patients for pelvic inflammatory disease, we need to start with the basic workup. This includes doing some blood tests in the forms of RPR, HIV, inflammatory markers, cultures if the patients are pyrexial, and an arterial blood gas depending on the severity and instability of the patient. Stable patients do not require routine arterial blood gas. A urine pregnancy test is essential to help us make the diagnosis of PID without losing the fact that the patient could also be pregnant with an ectopic. A urine MCNS is also helpful to identify the bugs allocated in the disease. Microscopy of vaginal discharge is useful to support our diagnosis of PID and is a great tool where available. Endocervical swabs, especially for chlamydia and gonorrhea, can help in the directed therapy and confirmation of the diagnosis. These, however, are not readily available or are not always routinely done. This is a great opportunity to take into account if the patient has had a recent pap smear and whether or not one should adequately ensure it gets done either inpatient or at the follow-up. When it comes to imaging our pelvic inflammatory disease patients, pelvic ultrasonography is our imaging modality of choice, especially since it gives us the option of a color flow Doppler. This can help us determine the blood flow through the tubo-ovarian abscess, especially if you suspect torsion. If our ultrasound is inconclusive or unable to guide us in the diagnosis, a CT scan is the next imaging modality of choice, thereafter followed by an MRI, depending on availability and cost factors. When managing our patients, we start with supportive management. This comes in the form of hydration with IV fluids, analgesia in the form of oral, IV, or IM, antiemetics, commonly used are Maxilon or Ondansetron, depending on the severity of the patient and the setting, antipyretics, especially if patients remain pyrexial, in the form of Pafalgan. Regular observations need to be done by the nursing staff, especially heart rate, blood pressure, temperature, and respiratory rate. This helps us to assess improvement or worsening state of the patient. Remember to keep the patient nil per mouth if they require surgery, and to always board the chronic meds, especially the ARVs, and to treat syphilis if their RPR rapids were positive. Hospitalized patients requiring IV antibiotics. The antimicrobial cover for the wide range of bacteria is required as well as anaerobic cover. So which IVs do we use for our patients? The following recommendation comes from the UK guidelines as well as our adapted Tygerberg guidelines, which include the use of a second or third generation cephalosporin as well as a tetracycline. This can come in the means of cefotoxin 6 hourly or ceftriaxone 1 gram 12 hourly, doxycycline 100 milligrams twice a day, IV or oral. However, this is quite a painful IV injection. Therefore, the oral route is always preferred. Flagyl 400 milligrams oral or IV, not a requirement, but can be added based on the severity of the patient, the risk factors involved, which mostly allude to most of our patient population. Therefore, we tend to treat with anaerobic cover. The CDC, however, recommends that clindamycin 900 milligrams as well as gentamicin 2 milligrams per kg loading dose, followed by 1.5 milligram per kg 3 times a day as the ideal inpatient IV-directed therapy. Both regimens showed clinical improvement in 80 to 90% of the cases. In a meta-analysis of 10 studies done comparing a cephalosporin, usually in combination with doxycycline, with clindamycin plus gentamicin as per the CDC, the short-term clinical and microbiologic cure was similar with each regimen. Therefore, we tend to rather go with the recommendation of treatment line number 1. The alternatives, based on patient allergies, no availability of the drugs, or cost factors, are as follows. The CDC recommends ampicillin sulbactam 3 grams IV 3 times a day and doxycycline 100 milligrams twice a day. In South Africa and Tygerberg setting, we use IV augmentin, being amoxicillin clavulanic acid. This offers a similar cover as ampicillin sulbactam, therefore it's recommended. Azithromycin 500 milligrams IV daily for 48 hours, followed by 250 milligrams daily for 7 days, as well as the addition of flagyl. These are the alternatives as recommended by the CDC. The UK guidelines recommend alternatively using ciprofloxacin 200 milligrams, doxycycline, and flagyl for a full duration of 14 days. They all advise that we can switch to oral antibiotics after 24 to 48 hours of clinical improvement. This decision is based on the patient's signs and symptoms and your clinical judgment. When we decide who gets surgery, be it open or laparoscopic, there is lots of debate about the indications for surgery, and after looking at numerous studies, the decision was generally any patient that has generalized peritonitis, an acute abdomen, or in whom you suspect tubo-ovarian complex torsion, a severely unstable patient, especially ones that are shocked, a patient that has recurrent PID attacks, and any failure of response to IV therapy 48 to 72 hours after initiation of therapy. It has been declared that these patients generally require surgical management. Laparoscopy is always the gold standard, especially when the diagnosis is uncertain, as direct visualization of the anatomy or the abscess can be managed then and there, especially if a simple incision and drainage will be useful. Laparoscopy can be quite a challenge in our setting, mostly due to availability of equipment and the operator confidence and skill. However, it is to note that it is still the diagnostic tool of choice compared to an open laparotomy. Just to note that a decision to take a patient to theatre for pelvic inflammatory disease should always be in association with the consultant and the clinical picture. When looking at special populations and treatment for PID, pregnancy is extremely uncommon to find a diagnosis of concomitant pelvic inflammatory disease, as pregnancy is seen as protective for this disease. However, it usually occurs within the first 12 weeks, and if this is the likelihood, then the patient requires admission and IV therapy. IV therapy along the means of ceftriaxone and azithromycin, especially as doxycycline is contraindicated. 5 to 7 days inpatient therapy is normally adequate, considering the fact that you can switch to oral therapy after 24 to 48 hours of clinical improvement. If a patient is known with a penicillin allergy, an IV cephalosporin with doxycycline is quite effective to cover and treat PID. One can also follow the CDC guidelines, which include the use of clindamycin 900 mg IV with gentamicin. Intrauterine devices. These do not appear to increase the risk of PID. However, these patients should be closely monitored. One should consider removal if the patient does not respond to therapy or worsens after admission. HIV positive patients do not require any added or additional treatment. The treatment is the same. When converting to oral therapy, all guidelines have the similar effect that patients require a 14-day outpatient therapy course of doxycycline and Flagyl. If a patient cannot tolerate doxycycline or are pregnant, then azithromycin for 7 days is adequate. Flagyl, especially in the case of a pelvic abscess, if cannot be tolerated, the alternative is clindamycin. However, Flagyl is always our first line. When looking at the complications of pelvic inflammatory disease, it's always good to note in a patient's history to help us direct our management and guide them in terms of future concerns. Complications can include dyspareunia, recurrence of PID in up to 25% of cases, but this is mostly due to the lack of adequate treatment or failure of patients to present for treatment. Infertility is quite a severe complication, mostly due to tubal factor, especially when there's tubal damage. The rate of infertility after a single episode of PID can be as high as 12%, going up to 25% after 2 episodes and 50% after 3 episodes. This coincides with the increased risk of ectopic pregnancy, especially following hospitalization for PID. And this mostly comes down to the fact of tubal damage. After 1 episode of PID, the ratio of ectopic pregnancy to intrauterine pregnancy is 1 in 15. After 2 episodes, it's 1 in 6. And after 3 episodes of PID, it's 1 in 3. This is quite a high statistic. Always advise patients about these complications. They are also at risk of formation of adhesions, a persisting hydrosalpinx, pyosalpinx, or a tuboovarian abscess. This can be associated with the chronic pelvic inflammation, especially due to recurrence or associated pyogenic infections. Most patients also suffer with chronic pelvic pain, sometimes as high as 20% of patients. They can include dysmenorrhea, dyspareunia, and severe backache, going hand in hand with dyspareunia. Mortality occurs occasionally, mostly in the situation of severe disease manifesting with septic shock or multiple organ dysfunction syndrome. Thankfully, this is not a common statistic, but always a complication to keep in the back of our minds. Just as we finally have treated the patient successfully and they are ready to go home, we must always remember counseling, especially when it comes to adherence to the medication, abstinence, minimum 14 days, ideally until after therapy and the patient is symptom-free, and the use of barrier methods. Barrier methods is protective from pelvic inflammatory disease and should be advised for each and every patient that we see in our consulting rooms. Before they leave, we should hopefully issue our patients with a partner testing slip aimed at any sexual partner they have encountered within the last 60 days. One can just hope they are in contact with that partner or that it's not too many, but essentially all partners should be screened and tested at their local CHCs. It's always a good time to discuss contraception with our patients, especially to avoid the burden of unwanted, unplanned pregnancies. After discharge, the patient's follow-up is extremely important so that we can assess if the patient is improving or not after therapy, being it inpatient or outpatient. The ideal time to review these patients is 48 to 72 hours later to assess the severity. And of a fun note, after we successfully treated and discharged our PID patients, can we just ensure that it was not appendicitis? The ongoing battle of surgeons versus gynecologists, but we love our surgeons. Let's be friends. Thank you for listening to my talk on PID. Here are some references. That's it, folks. Thanks for listening. Have a good day.